Right. Good morning or good afternoon. We're just waiting for people to be able to enter into the session here. And then we'll get started. I think we'll probably have people flowing in as we move along here. I wanted to give a welcome to all of the attendees and our moderator and our speakers here today on behalf of CAPER. This is the first week of the CAPER Academy, and we have this event every fall, and it's a 5-week series designed to really highlight important clinical topics in pancreas care for particularly for medical professionals, but really for anyone who knows or cares for patients with pancreatitis. This was organized by CAPER. It is one of several initiatives under CAPER designed for pancreas education. And if you are interested in learning more about CAPER, you can go to our website. It's caper-pancreas.org, or just Google CAPER Pancreas and it will bring it to the top. I do want to thank Dr. Evans-Phillips and Dr. Luckhurst, who will be here next week. They spearheaded the organization of these sessions and really have a wonderful lineup. So I will turn it over to Dr. Evans-Phillips, who will moderate for today's session.
Thank you so much for the wonderful introduction and welcome to everybody. We're so excited actually for the speakers that we have, and today we're going to be talking about acute pancreatitis. And so we're very honored to have with us two excellent speakers today who are really wonderful leaders in the field. And so Dr. Peter Lee is going to start out actually by telling us a little bit about acute pancreatitis and etiologies, and he is clinical associate professor of internal medicine at Ohio State University, the Ohio State University. And Dr. Lee is a specialist in caring for patients with pancreatic diseases and disorders, as well as other conditions that require advanced endoscopy procedures. His research focuses heavily on acute pancreatitis, and so again, we are thrilled and honored to have him here with us today. A reminder to all the attendees to just place any questions you might have into the chat. We'll have Dr. Lee's talk, and then we'll have an additional talk actually by Dr. Sultan Mahmood, who will be joining us shortly. And then we'll have some discussion after that regarding any clarifications or questions that the attendees have. Thank you so much. And without further ado, Dr. Lee.
Thank you, Dr. Phillips. Just gonna share my screen here. Okay. Can everybody see my screen? Okay, cool. So I'll get right into it. So some learning objectives. So my hope is that I can help you recognize common etiologies and important etiologies of acute pancreatitis. I will refer to acute pancreatitis as AP from here on out because it's a mouthful. And then help understand and explain why recognition of etiologies matters, and then list some common pitfalls in determining etiologies of AP, then moving on to why being able to assign severity can impact management, and then finish the talk by listing some do's and don'ts of initial management of AP. Let's start with the case. So 55-year-old male with acute abdominal pain, lipase of 2000, mild transaminitis, but normal, no cholestasis. White count is 15. CT scan is shown here. Edematous pancreatitis. Gallbladder shows no stones. Ultrasound was not done. Triglyceride was in the 300, and the patient states that he doesn't drink. So what caused the pancreatitis? You're seeing this patient for the first time. Is it even important to consider that? And then a series of questions come to mind, right? When you're seeing these patients in the ER or on the floor, when will you feed the patient? What will you feed the patient? What about pain management? And what should be the discharge plan? These questions sort of occur simultaneously. Now, I want you to think about the answers to those questions, but in the interest of time, I will tell you what happened subsequently, just to stimulate conversations and discussions. So the patient was started on clear liquid diet, advanced to solids in 5 days, dilaudid for pain, discharged with GI follow-up, labeled as idiopathic acute pancreatitis because there was no stone in the gallbladder. Unfortunately, GI clinic is very busy. So 3 months out, outpatient visit. And in the interim, the patient is readmitted with gallbladder wall thickening, right upper quadrant pain, and the diagnosis is acute cholecystitis. So what happened here? So in sum, this patient probably experienced index gallstone pancreatitis with the first admission. And then because the gallbladder stayed in, he unfortunately experienced further biliary event in the form of cholecystitis. Before we dig deeper into etiology, let's talk about the initial management real quick. So in mild and even in moderately severe pancreatitis, initial oral solid diet may reduce length of stay without exacerbating severity. So it's safe to do that, contrary to what was done for this patient. And in moderate pain, if the patient's open to it, which is going to be hard in the United States, NSAIDs may be sufficient for pain management. There's some emerging evidence, mainly from Asia, that COX-2 inhibition, so in the United States, that would be celecoxib, may prevent even progression of acute pancreatitis. We want to avoid morphine because there's some experimental evidence of harm. So that's kind of the initial points about initial management. What about etiology? So gallstone acute pancreatitis. What happens to gallstone pancreatitis when you don't take the gallbladder out? And this is in the mild severity category. And you can see a whole host of subsequent events that can happen. And cumulatively, up to 1 in 5 patients at 90 days can experience one or more of these events. So attributing causality to gallstones is important. And you also want to take out the gallbladder if you determine that the patient's AP is from gallstone. But it's a little bit difficult, right? Because we keep talking about mild pancreatitis, moderately severe pancreatitis. How do you define that? And how do you assign causality to gallstones? Well, I think a helpful starting point is to go into one of the landmark trials that looked at and proved that cholecystectomy is helpful in index gallstone pancreatitis. Let's see how they defined gallstone etiology. So if they saw stones or sludge on imaging, if the bile duct is dilated or ALT is elevated, then that's how they assigned gallstone as an etiology. But if you actually look at the cohort that was enrolled, vast majority of them were determined to have gallstone etiology just based on the fact that they had stones or sludge on the imaging study. And of course, they had to rule out, alcohol use disorder and other etiologies as well. In terms of mild severity, they defined it with CRP, and the patient needed to be off of any opioid analgesic and tolerate a normal oral diet. And then they needed to be a little bit younger than 75 and no other severe comorbidities. In another trial, again, imaging confirmation of stones or sludge was the defining criterion for assigning etiology. So that's helpful to remember. What about predicted mild severity? Well, they use the bicep score, which most of us know probably well, and you can easily find that online on MD Calc, or if there's no organ failure or local or systemic complications. So touching on the gallstone pancreatitis, and also managing nutrition, in mild and moderately severe pancreatitis patients, if there's no organ failure, fluid or necrosis in and around the pancreas, bicep score or HAP score is low, these scores actually have a very high negative predictive value in ruling out severe pancreatitis. In these patients, they stand to benefit from just feeding them low-fat solid diet, and that reduces the hospitalization, length of hospitalization in the trials. Causality to gallstone, it's just seeing stones or sludge on the CT, ultrasound, or MRI, and sometimes you need EUS, which is the most sensitive test to detect stones in the gallbladder. ALT, more than 3 times the upper limit, is very specific. So when that's really high, it is very likely that the etiology is gallstones. Let's move on to the second case. 33-year-old female with abdominal pain. This is her third admission. Normal LFTs. Again, pancreatitis on the CT. Gallbladder's there, no stones, sludge. Fatty changes in the liver. The white count is up. Ultrasound was done in this case. And the lipase was elevated. Again, she adamantly denies that she drinks. So what could have caused AP? What will you give the patient for pain? And are there any other tests that you could consider doing to further evaluate? And again, I will go on to what happened to the patient. So the pain improved undilaudid. She was referred to GI clinic, but GI clinic's too busy. 3 months away, discharged with Percocet. And unfortunately and tragically was readmitted a week after being found down unconscious with a pill bottle next to her, suspected of a potential suicidal attempt. I know this is a little dramatic. It's loosely based on true cases, but I did want to point out some very important points up for discussion, and so please forgive me for being a little dramatic here. CT scans showing worsening changes of acute pancreatitis. So what could have happened? So this patient was later found to have alcoholic etiology for acute pancreatitis. But then again, some common difficulties and challenges emerged. How do you attribute AP to alcohol? Does everyone who drink heavily or regularly develop AP? What about patients who drink regularly but also has gallstones? Is AP in the setting of alcoholic etiology a disease or a symptom of a deeper disorder? So number one, how do you attribute AP to alcohol use? Well, you need to have been drinking at least 4 to 5 standard drinks every day for 5 years, according to epidemiologic studies, in order to be at increased risk. So we can't just assign alcoholic etiology to patients who recently drank. So history is important. There are some helpful biomarkers of recent or active alcohol use. I feel like they're helpful to open the discussion about alcohol use, especially if the patient denies drinking history. And I also find that talking to a family member for collateral history also is really helpful. But we have to remember lifetime prevalence of AP in heavy drinkers is about 2 to 5%, which should really cause us to reconsider this etiology if things are not fitting nicely. And I'll go into details about it a little bit more in the subsequent case. Now, what about patients who drink regularly but also has gallstones? It's very difficult to distinguish between the two. Is AP from alcohol a disease or a symptom of a deeper disorder? Well, I would like to make the case that we need to be treating these patients as persons, meaning we have to remember that patients with alcohol use disorder often have concomitant mental health and also social stressors, as listed here, which is quite striking. And failure to recognize that is to just treat the symptom. And that's the point that I wanted to really demonstrate with this case. This is a very helpful review article that was published in the NEJM this year, in fact. And I really love this line. The enduring myth that alcohol use disorder results from moral failure continues to influence public and professional views of the condition. Up to 50% of the risk of alcohol use disorder is thought to be inherited. This should really cause us to really have and cultivate compassion for these patients. And that's really the main point. And the subsequent lines really reiterate the points that I made earlier. And then there are some key points. I'd highly encourage everybody to look this up, and it's an open access, and read it to better understand holistically what some of these patients go through and some of the effective treatments that are underutilized, for example, pharmacologic agents, and also other resources that are available for this cohort. Moving on, 64-year-old female with ongoing severe abdominal pain, suspected secret alcohol abuse, forced ER visit. Her PATH, which is a biomarker to look at 2 to 3 weeks back alcohol exposure, was positive. Underwent 3 CT scans in 1 month, and it shows Stranding around the pancreas, dilated pancreatic duct, no evidence of a mass. Consider chronic pancreatitis in light of positive path. That's what it says. Vital signs are normal. She lost about 30 pounds in the last month. She's discharged, sees pain management for chronic pain, follow-up in GI clinic 3 months later. Unfortunately, the LFTs progressively worsens, becomes cholestatic, undergoes an EUS-FNA, which is shown here in the video, and unfortunately the EUS finds a neck mass and liver lesions, and was diagnosed with metastatic adenocarcinoma. So you might be wondering, well, what? This never happens. I mean, how is this possible? 3 CT scans and they didn't find this mass. Let's go through the literature. So malignancy, you have to remember 1% of all AP causes is from malignancy. Sensitivity of a regular CT for masses that are less than 2 centimeters can be as low as 45%, meaning up to 55% of true cancers can be missed on CT. Not all dilated pancreatic duct is secondary to chronic pancreatitis. You have to remember pre-malignant condition like main duct IPMN, which is very difficult to diagnose, can also present with AP and dilated pancreatic duct. So beware of anchoring bias, especially when things don't fit quite nicely. So especially in patients with dilated PD, pancreatic duct, in the absence of calcifications, and a lot of these patients, of the ones that I diagnosed, they often have profound weight loss even preceding the onset of AP. Path is negative, have a heightened index of suspicion, and don't think that the CT rules it out reliably. Last case, 45-year-old, I have 1 minute. Male with 7 days history of severe abdominal pain. The patient is in SIRS, febrile, thinking that this is biliary etiology. Bile duct is dilated, but there's no stone in the bile duct, but there are stones in the gallbladder. A little bit cholestatic, but normal bilirubin. Gets started on TPN after MPO. The patient doesn't get better, continues to have fevers, put on antibiotics. IR gets consulted during the first week of the admission, gets a 12 French drain placed, no improvement, drain doesn't really put out much, progresses to multi-system organ failure, and then after that gets transferred, but unfortunately rapidly decompensates and passes away. So what could have been done? Should we have forced the patient to eat earlier or tube feeds, earlier antibiotics? If the patient didn't improve, should we have just debrided the necrosis? What about aggressive fluid resuscitation or early ERCPs? Well, early tube feeds may improve outcomes, especially when you compare that with TPN. It's better, much better. So always prefer oral and then enteral and then TPN as last resort. Infected necrosis, especially during the first week, even in febrile patients, is very rare, less than 10%. So SIRS response accounts for vast majority of fevers in the first week, even in necrotizing pancreatitis patients. And role of antibiotics for primary prevention of infection is not supported by evidence. Early necrosectomy, we really moved away from this, and our surgical colleagues would tell you the history behind it. That's not indicated, and no evidence that there's aggressive fluid resuscitation, excess of 5 liters, may harm the patient and doesn't really improve outcomes at all. And early ERCP in the absence of cholangitis does not prevent progression. This is a graph that shows one of the landmark observational studies that looked at timing of surgical intervention and mortality. The longer you wait, the better it is for mortality. This was a landmark trial that was terminated early. They showed that they were killing more than half the patient by debriding necrosis too early, which is within 2 to 3 days, compared to after 2 weeks. And this was done in the 1990s. So quick note about early percutaneous drainage should be really avoided unless there's firm evidence of infected necrosis and the patient's on antibiotics and sepsis is progressing despite maximal therapy. And this is just to reiterate the importance of transferring the patient in these instances early on rather than waiting or intervening without multidisciplinary consultations. These are summary of do's and don'ts, but I'm unfortunately out of time. But this is just a recap of what we talked about throughout the 4 cases that I shared with you. So what about the other causes of AP? Well, I didn't have time to go over all of them. But fortunately, IAP just published their excellent guidelines. Very good resource to dig in deeper. And I was fortunate enough to be part of a group that wrote a very practical guideline on, not guideline, a review on practical management of AP in the first 24 hours. And I'm always happy to answer questions or help in any way outside of this context, and my email is here. Thank you.
Thank you so much for a wonderful overview, Dr. Lee. That was really fantastic, and certainly not to worry. I know we got started a couple minutes late, so appreciate the thoroughness and so forth. In the interest of time today, we'll move actually to the next talk, but to all the participants, don't go anywhere. Please feel free to place any questions that you might have into the chat. And I'll be happy to read those out, and we'll have a short discussion with Dr. Lee and Dr. Mahmood at the end of the session today. I also wanted to welcome my co-moderator, Dr. Casey Luckhurst, who's here with us today, to say hello and thank her for her efforts in helping to put together this series. Without further ado, though, I'd like to introduce Dr. Sultan Mahmood, who is someone we are honored to have here today. He is a colleague at UPMC of mine, and he is a specialist in gastroenterology and has specific interests actually in medical education and third space endoscopy. He has focused extensively actually on improving quality metrics for endoscopy and colonoscopy, and also in medical education and third space endoscopy. And he is currently the director of third space endoscopy and advanced tissue resection at UPMC, and we're thrilled to have him here today actually to talk a little about the role of therapeutic endoscopy in acute pancreatitis. And so, Dr. Mahmood, thank you so much for joining us. Please feel free to take it from here.
Thanks a lot for this opportunity, and hopefully you guys can hear me. Okay, right, yes. Sorry for being a little bit late too. There's always this one case that's before the presentation that goes on for longer than expected. Can you guys see my slide?
Yes, coming through loud and clear.
Okay,
Thank you.
good. So the role that was assigned to me was to discuss the role of endoscopic intervention for the management of acute pancreatitis and its sequelae. It's a very broad topic, but I'm going to talk about some of the important things that we do within the 20 minutes that was allotted to me. I have no financial disclosures relevant to this presentation, but I did get some of the videos and animations from other sources. So let's just get into it. This is an older study looking at the overall prevalence and the natural history of acute pancreatitis, but I think this also holds true today as well. When you see the patients coming in with acute pancreatitis, most of them will present with interstitial pancreatitis, which is going to be more than 2/3 of the patients, and less than 1/3 of the patients will have necrotizing pancreatitis, and less than 5% of the patients will go on to develop complications like an abscess or a pseudocyst. That's the natural history that we would expect in anybody coming in with pancreatitis. There are some complications that are common after an episode of pancreatitis, and it also depends on what type of pancreatitis you had to begin with. Almost 20 to 25% of the patients on presentation will go on to develop some complications. If the initial presentation was with acute interstitial pancreatitis, the most common complication that you would see will be acute peripancreatic fluid collection, which happens in more than 10% of the patients. And if the presenting complaint was acute necrotizing pancreatitis, then 5% of those patients will go on to develop acute necrotic collections. Then over time, these will progress to a pancreatic pseudocyst or a walled-off necrosis in 1/3 of the cases. Other complications, the most common one is going to be pleural effusion. Most of that is related to the fluid resuscitation that we provide as part of the management of acute pancreatitis. And very rarely this will be related to a pancreaticopleural fistula or other causes. Multi-organ failure, colon fistulas, and cholangitis, fortunately, are rare. So what's the role of endoscopy in the management of acute pancreatitis? It's important to remember that ERCP used to be kind of a diagnostic procedure in the past, but that has definitely changed now. So when we talk about the diagnostic role of endoscopy in acute pancreatitis, we're talking about endoscopic ultrasound, which is a very minimally invasive approach, and the risk of complications with that is extremely low. So we use the endoscopic ultrasound for diagnosing a CBD stone when the diagnosis is not clear or the patient cannot undergo an MRCP procedure. And we also find patients who have microlithiasis in the gallbladder, which can be a potential cause of the acute pancreatitis and sometimes for the diagnosis of pancreatic divisum as well. And when it comes to therapeutic, this is where endoscopic ultrasound and ERCP has a role. It depends on how early we are after the acute pancreatitis episode that we might need to do an ERCP for biliary obstruction or cholangitis, or if it's more than 4 weeks, then it's going to be intervening on pancreatic pseudocyst or a vault of necrosis, and we will talk about that in the coming slides. So less than 4 weeks, the most important role within the first 4 weeks for ERCP would be for the management of gallstone pancreatitis or persistent stones in the bile ducts. It's important to understand what the natural history is. Most patients who come in with biliary pancreatitis, they will have passed the stone by the time that they will present to you. So the damage has already been done. And in fact, it makes sense too for the stone to cause pancreatitis. It has to be right at the ampulla. So it's like almost on its way out. And just there it causes the pancreatitis. And most of the times it will pass along into the GI tract. But the damage that has been caused by the pancreatitis will follow its own natural course. And in less than 20% of the cases, there will be a persistent stone that is seen on imaging that will need further intervention with ERCP. If the patient does not get their gallbladder removed, there will be a common question which is asked, like, what's my chance of recurrence of pancreatitis? And most studies show that the chances of recurrence of pancreatitis is 30 to 50% if the patient does not undergo the cholecystectomy procedure. Timing for ERCP for an episode of acute gallstone pancreatitis has been a subject of debate in the past, but I think that now we have very good guidelines and studies available that there is no role of urgent ERCP less than 24 hours because that does not change the natural course of pancreatitis. So once the stone has caused pancreatitis, removing the stone is not going to change the natural course. So the indication for ERCP is not the pancreatitis, it's actually other complications from the stone like cholangitis. So the patients have persistent biliary obstruction with itching or worsening hyperbilirubinemia. That would be the reason for a more urgent ERCP rather than the severity of the pancreatitis. So if the patient does have a persistent stone, we can go ahead and do the ERCP within the first 72 hours. And if the patient is not stable enough, that can be delayed even further because that, like I said, it does not change the natural outcomes from the acute pancreatitis. This is just a brief graphical depiction of the ERCP procedure in case you are not familiar. So the common bile duct and the pancreatic duct, they share a common opening, which is at the level of the ampulla. Sometimes you would see a separate opening too, but in most patients coming in with biliary pancreatitis, they will have a common opening. And the stone has to make its way all the way at the ampulla to cause the blockage of the pancreatic duct and cause the pancreatitis episode. So we'll get the scope right to the opening of the papilla, we'll pass our wire into the bile duct, and then over the wire, we can perform the sphincterotomy to open up the ampullary orifice. And once that is performed, we can use a balloon to pull out the stone. The ERCP procedure by itself does carry a risk of pancreatitis too, which is between 5 to 10%. So which is another reason that you should not be jumping into doing an ERCP unless you have a confirmation of a gallstone. Other places within the first 4 weeks where we do have a role is the placement of the NJ tube. Paul did talk about some of this in his presentation too, but enteral nutrition, we don't have a lot to offer in patients with acute pancreatitis in the first 4 weeks, but enteral nutrition is something that we can offer, and this is something that we can facilitate as gastroenterologists, is to initiate early enteral nutrition because that has been associated with improved outcomes in patients coming in with acute pancreatitis. The natural natural course is that more than half of the patients with coming in with severe pancreatitis will not be able to tolerate oral feeding. And those are the patients that we need to identify early and think about enteral nutrition. The debate is still out there about NG versus NJ feeding, but in our institution, we usually go for the NJ tube route in 95% of our cases, and that is done by us in the interventional endoscopy suite. We go in from the nose with the ultrasound scope into the jejunum, put a wire in, and over the wire we can place that NJ tube. And some patients who need prolonged pancreatic rest, we can also consider placing a GJ tube, which is also done endoscopically as a prolonged way of providing enteral nutrition while the patient cannot tolerate an oral diet. 4 weeks out is when things start to change and we have like more fancier tools available to take care of these patients and the complications. I really like these Atlanta classifications, and I think as gastroenterologists, everybody should be familiar with these, which is that the 4 week is the cutoff mark when the fluid collection or the necrotic collection develops a wall around it. It can happen slightly earlier too, but 4 weeks is a safe period after which we can feel comfortable draining that collection internally, because if it's less than 4 week mark, there's always a chance that if you try to drain that collection, that may lead to the rupture or pancreatitis or peritonitis, which can be a huge problem. So if the initial episode, just looking at the top part of this slide, if the initial presentation was with acute interstitial pancreatitis, then the patient will develop acute peripancreatic fluid collection. And after 4 weeks, we will call that a pseudocyst. And at the bottom half, if the pancreatitis started off with the necrotizing pancreatitis, then it will be called an acute necrotic collection. And after 4 weeks, we can call it a walled off necrosis. And both of these conditions on the right side of the screen, the pseudocyst and the walled off necrosis, can be managed endoscopically. This is just a picture demonstration of these collections. As you see the top left image, that is the acute pancreatitis episode with all of that fluid and the stranding around the pancreas. And if you look to the right side, it changes into this very homogeneous, clear collection, which is a pancreatic pseudocyst. And at the bottom left side, you see this hypoenhancing area inside the pancreas, which is a sign of the acute necrotizing pancreatitis. And over time, this will go on to the right side to develop into this large walled off necrosis, which can be managed endoscopically if needed. The paradigm for management of these collections has definitely evolved over time. Initially, before the 1990s, again, I've not seen that era, but surgery used to be the mainstay for managing these collections, opening them up with the laparotomy and taking out these collections, doing surgical debridement. And then after 1990s, the percutaneous drainage became the mainstay, which required placement of these drains inside these collections and then exchanging them out. And since 2007 and the advent of these endoscopic drainage options, now we have a lot of tools available, including the Axios stent that we will talk about, and most of these are managed with endoscopy these days. So just comparing these three techniques, they still have a role to play, like the surgical technique in patients who are not a candidate for endoscopic drainage, or the collection is still in the early stages within the first 4 weeks. Then surgical drainage is an option, but it is associated with a very high morbidity and mortality and long-term complications. Percutaneous drainage, on the other hand, is a less invasive approach, but as you can imagine, it requires those drains on the outside, which can lead to persistent external fistulas, which can be a huge area of concern. And the size of those drains is limited, and that does interfere with taking care of very large necrotic collections, which may not be feasible with percutaneous drainage. Endoscopic drainage we have a lot of options, and we'll talk about those, but requires placement of these plastic double pigtail stents into the collection, or putting in a metal stent to drain the collection into the stomach, and then we can debride it with endoscopy. It does require some technical expertise by an interventional gastroenterologist, and in some cases, if the debris or the necrotic tissue is very large, endoscopic drainage can sometimes be an issue. So definitely better than the percutaneous, but maybe not as good as surgery if the patient contains very large collections. So for endoscopic drainage, there are a few options available. Transpapillary drainage can be performed if it's a really small collection which is communicating with the pancreatic duct. You can actually go transpapillary, put a double pigtail stent into that collection and drain it into the duodenum. But the most common way that we manage them now is with transmural drainage. So we have this newer stent available to us now, which is called the Axio stent, which is a dumbbell-shaped stent that we can place into this collection. It can provide us a window for accessing that collection to doing the necrosectomies. But this has become kind of the mainstay that how we manage these collections these days. Sometimes we can actually also use the percutaneous access provided to us by intervention radiology and use that drain to go in with our ultrasim endoscope and do necrosectomy, debridement, or whatever needs to be done. So as GIs, we don't like to do any large studies, unfortunately. So most of the data is actually driven by smaller studies, which has given us, I guess, a standard of care at this time. So, but we do have some studies. So, Pancreas trial was one of the trials which was comparing the step-up approach, which is the use of the percutaneous drains versus the open necrosectomy, and they found a much better outcomes in terms of the organ failure and the complications from a step-up approach using interventional radiology rather than going directly to the necrosectomy. The biggest difference obviously was the organ failure, but the death rates were pretty similar in both of these cases. And then we do have studies comparing the step-up approach to the endoscopic debridement, which shows that the endoscopic debridement with endoscopic stent placement is associated with lower risk of complications, lower ICU stay, and lower hospital stay as compared to the step approach, which is done by interventional radiology. So endoscopic necrosectomy is better than step-up approach, and step-up is better than surgical necrosectomy. And we do have data for mortality as well, which again, I mean, coming from smaller studies, but still this is what we have available. But in patients who are coming in with severe pancreatitis and at high risk of death at baseline, the risk of death is much higher with the surgical approach as compared to the endoscopic approach, and be it the open necrosectomy or the minimally invasive surgical necrosectomy. So if you are going to go with any approach, endoscopy is going to be preferred. And then if you are going to go the surgical route, instead of an open necrosectomy, a minimally invasive with laparoscopic approach is going to be preferred. So this lumen opposing metal stent that I was talking to you about, that was introduced back in 2007, 2010, and it has really revolutionized how we manage peripancreatic fluid collections, the wall of necrosis, as well as pseudocyst. The advantage is that these stents have a very wide diameter. They go up to 2 centimeters, and the endoscope size is around 9 to 10 millimeter, which means that we can go in through that stent into the cavity and do all of our interventions. This equipment is costly. One stent costs like more than $5,000. So it does add cost to the care, but I think the less number of procedures and the less time required for these interventions does make up for that cost. This is a visual demonstration of how the Axio stent works. Like I was telling you, this is a dumbbell-shaped stent. So this has 2 dumbbells on both sides, which can be used to oppose 2 different lumens together. And it has a central diameter which can vary depending on what type of stent you're using. But usually for these endoscopic drainage, we use a stent which is the largest size, between 15 to 20 millimeter. This is mounted on top of a linear endoscopic ultrasound scope. And the biggest difference now is that this is a cautery enhanced device. So we can cut through any lumen without using any dilations, and puncture like from the stomach into the fluid cavity. Then we will deploy our first flange into that cavity, like say it's a vault of necrosis or it's a pseudocyst, and then we will pull that back and deploy our second flange into the stomach or sometimes into the duodenum too. And once that is deployed, if essentially we've created this natural fistula from the pancreas or from that collection into the stomach, which can provide a conduit as well as help drain all of these collections. These stents usually stay in for like 4 weeks or so. During that time, we will do our necrosectomies and do whatever needs to be done. And eventually, if the repeat scan shows that the collection has completely resolved, then we can remove that stent. Other complication that you can see is pancreatic peritoneal fistula causing a persistent ascites, which is not responding to NJ2 feeding. That is the case where we can place a pancreatic stent. The same goes for a pancreatic pleural fistula too, that we can place this, do an ERP, put a stent in to provide drainage to the pancreas into the GI tract and help with the leakage caused by the pancreatitis. Endoscopic ultrasound, like I was talking to you guys before, we do see cases in which the MRI is not very clear about the diagnosis of stones, or in cases in which the MRI cannot be performed. Endoscopic ultrasound carries a very high sensitivity and specificity for picking up stones in the bile duct, including small stones. So that is the preferred way for us to do a diagnostic evaluation to look for that. And we can also find like pancreatic tivism and gallbladder microlithiasis too during the same evaluation. Some of the, without, again, we don't have time to go through all of this, but there are some other cases too where interventional endoscopy is involved. One of those is the development of a gastrointestinal fistula. The most commonly we would see that to the left side of the colon from a large necrotic collection. And if that becomes an area of an abscess or infection that needs to be drained, then we do have the option of performing a colonoscopy, putting an over the scope clip or suturing to close off that defect. Pseudoaneurysms are usually managed by interventional radiology, but we have been called a few times for patients who the aneurysm may not be accessible by the interventional radiologist. And there are some newer studies showing that the thrombin and coil injection with the endoscopic ultrasound is also a feasible option. And rarely, when you cannot perform an ERP to take care of a bile leak, we do have EUS guided drainage to put a stent directly from the stomach into the pancreas. So in conclusion, we can say the local complications are fairly common after an episode of acute pancreatitis, and we can quote a rate of 25% to patients when we see them in the hospital. Interventional GI plays a very important role, not just for the diagnosis, but also from a therapeutic purposes too, to manage these patients. And you should always think about endoscopic drainage as the preferred modality for managing patients who have a symptomatic pseudocyst and walled off pancreatic necrosis. And I do want to highlight symptomatic here because we do get a lot of calls with patients with a large collection, but if they're asymptomatic, we don't have to drain them internally. So this is the end. And if you guys have any questions, I'll be happy to answer them.
Wonderful. Thank you so much for the excellent talk, Dr. Mahmood, and also to Dr. Lee for his earlier talk. I really appreciate both of you joining, and I think we've had an excellent overview on both topics. To the attendees today, if anyone has any questions, please feel free to place them in the chat. I'm happy to read them out for additional discussion. To get things going, I actually had a question for each of you, and so to start with Dr. Lee, you had talked some about etiologies and some of the puzzling aspects actually of the diagnostic process in acute pancreatitis, which can be a real challenge. And I wondered if you could talk a little bit actually about treatment or lack of treatment for acute pancreatitis and where that is at the current time and what things might be on the horizon.
Are you referring to like in-hospital treatment of all-comer acute pancreatitis? Oh,
Well, yes, I think that's a great place to start. For our attendees who are relatively new to the disease process, I think it'd be important to highlight, kind of the limitations that we currently have in terms of treating the disease and lack of options.
Yeah, I mean, I think, if you look at any paper on acute pancreatitis, the first couple of lines always begin with, "We don't have a treatment." And thanks to a lot of outstanding, bench researchers, I think we have come a long way. The most promising treatment, I would say, that have just, I think, finished phase 2 trial is a calcium channel blocker that blocks calcium channel in the pancreas that has shown some really promising results. I don't think that the results are published yet, but I do know that they will proceed with the phase 3 trial. And so that's kind of up and coming. I also know because inflammation is such a important event in acute pancreatitis, there's an investigator in the UK that's investigating tumor necrosis factor alpha inhibitor like infliximab and its role in treating acute pancreatitis early on. So that's also, I think we will hear from those investigators in the coming year. Now, I did allude to this before, but I think from what's published, COX-2, selective COX-2 inhibition, um, there is a couple of papers, actually one in the American Journal of Gastro, and then one just published not too long ago in Gut, where they use COX-2 in patients who already develop organ failure that seems to improve outcomes. It's almost too good to be true, and it's yet to be replicated in the United States. So NSAIDs, for what it's worth, is showing some promise as well. So those would be the three that I can think of, and then because of fat lipolysis mediated organ failure mechanism, there are some early studies looking at preventing lipolysis early on in early necrotizing pancreatitis to improve outcomes. So some exciting things in the pipeline, and then there's more to come actually down the line. So that's kind of, I don't know if that answers your question.
I think that's a great start. And so, yes, thank you so much for highlighting both where we currently stand, with limitations, as well as the future promise of new therapies. And so we'll be excited to hear more about those, hopefully in future Pancreas Academies. But that's a wonderful start. To Dr. Mahmood, I actually wondered if you might be able to talk a little bit about the trajectory of acute pancreatitis in patients who end up undergoing intervention, like what you described in terms of
Yeah.
drainage of complex walled-off pancreatic necroses and so forth. What things do you see, and what additional complications can sometimes arise?
Great, thanks for that question. I think it's a very common question that patients also want to know once you say, okay, now you're going to put a stent in me. Well, what should I expect next? It depends on where we're starting off with. So if the patient is starting off with a pancreatic pseudocyst, we would expect that to be a more clear collection. So you put a stent in one time, usually that would just drain out completely just with that stent, and we will not have to go in and do any interventions. So for those type of patients, for a pancreatic pseudocyst, we say, well, I'm going to put a stent in, I'm going to get a scan in 3 weeks. And if the scan looks good, I'm going to bring you back, take the stent out, and you're all done. And that usually what happens in 95% of the cases. On the other hand, ward of necrosis is a different beast altogether. It depends on what the extent of the disease is, where that collection is. I would say that in 90% of the cases, we are able to manage the necrotic collection on our own without the need for surgery or without the need for interventional radiology. So what I tell my patients is, okay, I'm putting the stent in right now, but you should expect 3 to 4 necrosectomy sessions within the next 2 weeks. And once we're able to clear all of this up, we're just going to let you get another scan in 2 or 3 weeks. And if the scan looks good, then we go in and take that stent out. That will vary depending on how much necrotic tissue we are dealing with. Interestingly, we do put these patients on coke. A lot of times, coke will burn through that necrotic tissue, open that up, and pineapple juice will do the same thing too, which still blows my mind as to how that works. But it's pretty impressive. You see a large hard tissue, you put them on pineapple juice, and they come back, and it's all become very slushy. So there is some, I guess, enzyme in there which does that. And we can also use hydrogen peroxide and some other chemicals too. But necrotic collection requires 3 to 4 interventions. Pseudocyst, usually just the one stent is enough.
Wonderful. Yeah, thank you for clarifying some of that, especially for, again, our audience who are still learning about these processes and, trying to make sense of what they're seeing in practice. Agreed. It is pretty impressive sometimes what substances can do that we otherwise, consume every day. So yeah, Coca-Cola, there's no disclaimers here, but yeah, that's, any cola product actually has been used, with some efficacy in this field. So pretty amazing. And thank you for that answer. I'll open it up again to the audience and to Dr. Bellin also if there are any additional questions. And if not, I'd like to thank both of our presenters again. This is really fantastic. And your talks will be posted as part of the CAPER Pancreas Academy series as a webinar for people to view additionally when they have time to do so. I'd like to thank you for your time and attention, and also just advertise to those who are participating today that we'll have 4 more sessions actually on Wednesdays through September and the first Wednesday in October in order to talk about some additional aspects actually of pancreatic disease that we all have a lot to learn about.
Thank you.
Oh, thank you, Dr. Mahmood and Dr. Lee. Thank you, Dr. Bellin, and thank you to Barb and the rest of the LP team actually who have helped set this up. Thank you to CAPER. All right. Have a great afternoon, everyone. Thank you.
Thank you, everyone.